Welcome, everyone. Sonator is very pleased to be sponsoring this webinar and on this very relevant topic. As we all know, it's clear that COVID-19 has had an impact on healthcare and that contact tracing is becoming critical both in and outside of healthcare. Our focus today really is going to be on how RTLS can be an essential tool that can help automate what today are manual contact tracing processes and really help deliver value, not just during this pandemic, but also beyond. Before we get started, I would like to introduce the other speakers. I know Linda did a brief introduction, but I'm really happy to be joined by Keith Herron. He's the Industry Solution and Strategy Director at Infor Location-Based Intelligence. Infor Location-Based Intelligence has been a long-standing partner of Sonator's. And Jim Engelstead, Health Systems Engineer at Sanford Health. And Sanford Health has also been a long-standing customer for both Sonator and Infor. And you'll hear directly from both Keith and Jim a little bit later on this afternoon. Well, as we all know, so much is changing as a result of COVID-19, and healthcare and public health really are at the forefront of these changes. I'm sure many of you, just as we, continue to hear that consumer confidence is shaken. There's concerns about potential hospital-acquired infections and the ability to get safe treatment as hospitals navigate their way through COVID-19. Staff are concerned about their own exposure risk and are definitely working longer hours and harder than before. And hospital operations and revenues are also being impacted. So it's clear that digital tools that can help automate processes and lessen some of these burdens and risks are needed. And RTLS is such a tool. And it can help automate clinical processes and workflows, and we'll talk a little bit about some examples. Can certainly automate contact tracing. This automation and these process improvements that come out of automation can help burden the load on staff. There are ways to implement RTLS to help facilitate social distancing, which is also key as people both get back to work and as patients start to make their way to hospitals and clinics. And RTLS can really, as a result of all of this, provide accurate and reliable insights and analytics that can help put in place corrective action, precautions, and process improvements. So just a quick primer on RTLS, just since I don't know sort of the overall audience here. But essentially, RTLS, real-time location systems, are active solutions that can help locate and position people and things, so people, patients, and staff, and things, assets, mobile medical equipment, indoors and in real time. Many of you probably know there are a variety of positioning technologies, and the performance of your RTLS is going to be dependent on the type of technology used. Being from Sonator, I'll talk about our core positioning technology, which is based on ultrasound and has been proven to give the highest level of location and positioning accuracy from room to bay, bed, and even chair level. And the positioning accuracy that you get and/or the positioning accuracy that you require really is dependent on the use case and the technology that you use. So for the performance and the functionality that I'll be describing in the next few slides, all of that is going to be based on Sonator's ultrasound-based RTLS. Clearly, other technologies are going to behave differently, so it's important that you keep that in mind as you start thinking about your own requirements and use cases, and make sure that you're aware of sort of the technology parameters that you're working within. In addition to giving location accuracy and the position of things, the other value of RTLS is not only that it gives you that, location and position, but it does that in the context of other people and other things that are tagged. So who else was there? When were they there? What equipment was used? How long were they in the room? Where was that equipment when it was used? And how long was it in use? And if you think about it, all of these parameters are important in contact tracing and also important in understanding the parameters around social distancing. So how can RTLS help? I'm going to focus on 3 specific use cases: contact tracing, social distancing, and enabling a touchless or contactless patient flow or experience. And Jim and Keith are going to highlight examples of those as they talk through their slides as well. It's important, though, to note that, as stated in my last bullet on this slide, that RTLS is a scalable technology. So once you have that foundation and infrastructure in place, if your solution is flexible and scalable, such as sonotors, you can layer many other use cases on top at minimal cost and effort. And in most cases, the cost and effort really remains or is put on the fact that you need probably additional tags in order to be able to expand your use cases. So how does RTLS work in the context of contact tracing? So in this slide, what you'll see located at the top on the ceiling is a location transmitter. So that's a Sonotor location transmitter. It transmits ultrasound every second, and that ultrasound that's being transmitted is uniquely associated with the ID, the location of the room that it's in. So that ultrasound signal is then received by the tag that's either being worn by the staff member or the tag that's being worn by the patient, in this example on the wrist, or the tag that's affixed to a movable asset, and in this example it's on the side of the bed. So as that ultrasound signal is received by those tags, they then communicate via Wi-Fi to a server, and that information is then received by the third-party application software, and in this case it'll be Infor's Intelligent Insights location-based technology. And because now you have all that relevant information, you now know if in fact one of these people are infected and or present positive with COVID or any other hospital-acquired infection. You now have a trail and a trace of who was in contact with that infected patient, what room were they in, what equipment were they using, and what staff members were attending to that patient. And you can easily and quickly put together a path of that infection and ensure that the proper communication is going out to all of the infected people, and that all of the precautions and corrective actions are being put in place to properly clean the room, properly disinfect, etc. This can also translate to value and usability in asset tracking as well. So if an asset has come in contact with an infected patient, as I mentioned, that can be easily and automatically traced, ensuring that all the right precautions are taken to ensure cleanliness before it gets put back into the healthcare system. The next use case I'll describe is on social distancing and the value that RTLS can deliver. So if you think about some of the guidelines and parameters that are coming out through the CDC now in terms of, what is the appropriate distance that people should maintain and for how long is that social distancing relevant in the context of an infection being passed, specifically as it relates to COVID-19. So leveraging RTLS, you can set thresholds for rooms based on their size and the social distancing guidelines and parameters that should only accommodate a certain number of people. And you can do that in common areas such as a cafeteria or an atrium or a conference room. So in this example in the middle here, based on the size of this room, it could be that the social distancing guidelines would recommend that only 15 people were in this physical location. If a 16th person were to walk into that physical location, an alert could be sent to the appropriate people, letting them know that there are too many people in this common area, and as a result, again, corrective action could be taken. Another example is down in this bottom right where I have an example of a biomed lab, for example, where perhaps the maximum people based on, again, the size of that room should only be 4 people. With Sonitor's ultrasound RTLS, you can actually take a single location transmitter and create up to 4 unique zones with that single location. So each of these zones within these squares have a unique location associated with them. And so that if a person were to cross over that zone into another location where another person is, then an alert could be sent saying, guess what, somebody's crossed into this zone, we've got too many people, let's take that corrective action. So similarly, how social distancing can be applied in large common areas, social distancing can also be applied using RTLS in small areas that are maybe in open space, but could have specific unique zones associated with them to really be able to give you the opportunity to leverage the space in the best possible ways. In this scenario as well, par levels could also be set up based on the number of assets within a given zone and storage location. So if there are a number of assets within a location that falls below a certain threshold, an alert could be sent to have that threshold replenished, really providing sort of an automated and contactless way of ensuring that the process is followed efficiently. And that ties into my next example or use case, which is about touchless or contactless patient flow in clinics. And again, this can be applied to contactless processes in general, not just for patients, but also if you think about it in the context of asset management. So Jim is going to talk a little bit more about how they've applied RTLS at Sanford Health. But just to share this example in terms of touchless and patient contactless patient flow. At the Moorhead Clinic in Sanford, they've got processes set up that allow patients the ability to navigate their way through their scheduled appointment in an independent way. So a patient arrives and is assigned a tag and directed to the appropriate exam room. At Moorhead Clinic, they actually have color-coded maps that allow the patient to navigate their way independently to the exam room. Upon entering the exam room, because there's a location transmitter in the room and the patient has a tag, that patient's presence is communicated through the software, and it's Intelligent Insights in-for location-based solution in this scenario, to alert the staff that the patient has arrived in the exam room. So this helps also minimize any wasted wait time for both the patient and for the caregivers. Once the staff is alerted, they enter the room. The staff are also wearing badges and tags, and the visit can begin. At the end of the visit, the patient can then independently walk themselves back to the exit entrance of the facility. They drop their tag in the discharge box, and the visit is automatically ended and the patient is discharged. In addition, that sends notifications that the exam room is now available to be cleaned and prepped for another patient. So as you start thinking about getting patients and that confidence and enabling processes that help minimize the spread of infection, thinking about contactless and touchless patient flow or processes can really bring value to your healthcare facility. The last thing I'll touch on, and I mentioned, is that RTLS as a technology can be very scalable and flexible. And as a result, the ability to have a strong foundation, RTLS foundation in place, allows you to layer additional use cases and applications on top of it. So Sonator as a technology platform is an open integration platform, and what that means is that the positioning data that is received by Sonator can be fed into software solutions such as Intelligent Insights that can then enable a variety of use cases off of that same infrastructure and that same backbone. So that really helps facilities garner significant value out of their RTLS investment. And certainly as we think about today and the need for these automated tools that optimize processes, that limit and minimize physical contact where possible, and really can help trace the path of infection, you know, this ability to layer on solutions and use cases is critical because it really provides facilities the ability to get their staff really focused on what's critically important, and that is taking care of patients. So with that, I'm going to hand it over to Keith, who's going to talk about how all this data then that you can get out of your RTLS can be leveraged through reports and through various visualizations to help put in place these corrective actions.
So hello everybody. I am going to take a moment here to discuss why RTLS is such a valuable tool for helping prevent and mitigate hospital-acquired infections. Let me take a moment to make sure I'm able to share the right screen. And I'm hoping everyone is able to see my screen now. Can anyone tell me if they're not?
We need to go into presentation mode. That's into
Yep.
slideshow. That's it.
Are you seeing my slide now?
Yep.
Perfect.
Over to you,
That's
Keith.
what I needed to see. Okay, great. So, as we all know, healthcare facilities are at high risk for being a nidus for infection, since they attract all those people who seem to be sick, and some of them actually have highly communicable diseases. So it makes it a highly risky area for potential infectious disease contacts. So because of this, those organizations need to be prepared to quickly and efficiently diagnose the infectious source and then identify all potential contacts so they can isolate and treat those who are infected to ultimately stop the spread of the infection to their staff and patients and others. During a patient's visit, they'll encounter many different staff members and fellow patients as they travel from one location to another, while they follow the timeline of the activity that typically occurs from their initial arrival through to a final departure. And once a patient arrives, depending upon the type of infectious disease that they have and its mode of transmission, they can very quickly spread the infection to other patients or staff, equipment, and to the locations that they encounter. Those initial or primary contacts can then subsequently spread the infection to other secondary contacts, who can then continue its spread onward to others. So the longer it takes to diagnose the patient's infectious status, the more time there is for the infection to spread, and the harder it is then to recreate the path that the patient followed in a retrospective analysis and all the contacts that they might have had during their visit. So this little animation just shows some of those contacts that can occur. Organizations have typically dealt with this issue for many, many years, usually by having to manually review all the documentation of the initial patient's visit to identify which nurse or which provider or which other staff may have been involved in providing care and likely came in contact with the patient. The process is extremely tedious and time-consuming, often taking many hours to several days to complete that process, which allows the infection to continue to spread while we're waiting for the results. And often, though, the paper trail itself fails to identify any random or unexpected or unusual contacts, such as if the patient were to encounter other passengers in an elevator ride, or if there's a brief delay while they're passing in a hallway or standing in line, or if you have staff members who aren't typically on duty but are rotating through the unit, or they're unassigned to that particular patient. Or maybe you have other staff members who are just performing their duties in a random fashion, like environmental services, who may be passing near the patient in order to clean up a spill or something. There'd be no record of that anywhere in the patient record that would allow a contact tracing team to identify that that potential contact may have occurred. So with these types of random unexpected contacts, the typical manual recreation of contacts doesn't really work. It's impossible for them to accurately identify that those encounters even occurred, much less who might have been involved in the event. But if the mode of infection is virulent enough, and such as an airborne transmission from an asymptomatic patient like we're having now with COVID-19, then these exposures are no less dangerous than those that are more common interactions from your doctor or your nurse. So being able to identify even the random ones is a critical challenge that is not met well given the current technology for manual recreation. So to acquire the information needed to identify all infectious contacts with staff or equipment or locations and other patients, including those challenging ones we just talked about, it's necessary to rely on locating technologies that are uniquely designed to meet this exact use case. And although there are many different technologies that you could try, most don't have the accuracy or the speed needed to capture brief encounters between people, measured accurately enough to identify those encounters that might be clinically relevant enough that a transmission of an infectious agent might occur. The system has to be configured reliably to deliver at least room level accuracy, if not better, and identify movements at least every 3 to 5 seconds to provide meaningful data. And this kind of rules out many of your RTLS type systems that are Wi-Fi based or RFID based technologies, because they don't have the speed or accuracy necessary to deliver that data. So the software that uses the location data provided by the real-time locating system hardware should also be designed to allow rapid generation of a comprehensive list of all contacts with the identified infectious source. So let's take a look at the contact tracing report that's provided by the Infor location-based intelligence software platform. So you can get an example of what we consider to be an adequate or more than appropriate means of finding all the data you need to perform an adequate contact tracing. So once you've been able to identify that a patient is infected and you need to then find what contacts they may have had while they were in your facility, all you need to do is pull up in our system the contact tracing report screen, and then simply insert the patient's name and also the starting date when the encounter might have occurred. Within a few seconds, you get a list generated displaying every contact between the infectious source and every other RTLS badge patient, staff, or equipment during that time frame, providing their name, their role, the location where the contact occurred, the exact beginning and ending time and duration of the interaction, so you can determine, was it clinically significant or did they just pass in the hallway? And any text listed in blue on our screen can then be selected to drill further into the details for that badged entity or location to acquire a secondary contact tracing in a similar fashion. Since it takes just a few moments to generate the list, infectious control teams will likely be able to initiate action to mitigate the spread of the infection many hours to days faster than they typically would be able to do so using standard manual processes for contact tracing. And of course, the list is comprehensive. It identifies every RTLS badge person, place, and thing that came in contact with the infectious source. So it greatly simplifies the process of identifying secondary, tertiary, and further contact tracing by being interactive and allowing your team to generate a separate report for each item in blue. Simply by selecting it on the screen, you'll get a separate reading for that particular contact with all their potential subsequent contacts. So to make the system as successful as possible, we highly recommend the following best practices. First, you want to proactively implement a real-time locating system, hardware and software application before the infection is likely to hit your doors. It often takes several months to properly implement and test the system to ensure that it's ready for immediate use. So you'll want to start well ahead of time. Second, you want to ensure that you've chosen a reliable real-time locating hardware system that is capable of providing the accuracy and speed you need to generate meaningful results. You don't want to be wasting your precious time chasing improperly identified potential contacts who are really not within the right distance or in the right amount of time in order to have likely transmitted or received an infection. Third, you want to choose a software application that can not only provide highly functional reporting capabilities for contact tracing, like I've just shown you here, but you also want to make sure that it's a solid and well-tested company that can provide the support you need to keep the software running smoothly and can allow you to expand into other valuable RTLS-related use cases beyond just contact tracing. So you don't want just a pigeonholed solution that provides only infection control tracing. Some of those use cases may allow you to implement processes such as patient self-rooming, which I believe Jim will be talking about in a few moments, that can minimize the risk of infection transmission that can occur in communal waiting areas. And then finally, you want to place locating badges on everyone and everything that could reasonably be expected to come in contact with an infectious source. You'll be happy that you've done so when the infection arrives at your door. So with that, I'll hand this over to Jim and let him tell you more about how they've successfully implemented our system in their facility. Jim?
Thank you, Keith. I do not have any slides to go over here, but I'm going to tell you about the story of Sanford's journey through RTLS. I know the focus of this is to understand how RTLS can be used through contact tracing, but to get a better idea of some of the decisions we made and how we use the data, I wanted to go over briefly our history. So in the fall of 2013 is when we started our journey here at Sanford with RTLS. We signed contracts with Sonitor as our hardware vendor, and Intelligent Insights at the time, now Infor, to be our software vendor. You know, it was really at that point that our planning began, and there was a great deal of planning that took place up front. Our first two main use cases were asset management in our Fargo and Sioux Falls hospital locations, as well as an ambulatory workflow, like both Keith and Sandra mentioned, in our Moorhead clinic, which is one of our larger clinics. And there was a lot of planning that had to be done up front to really understand from the ambulatory workflow how we wanted the whole process to work from the time the patient came in the doors until they left. From the asset side, we really had to understand what assets do we want to badge, go through. In both instances, we had to go through the process of installing the hardware, coming up with a hardware design first, getting the hardware ordered, installing it, as well as badging the assets, which was a task in itself to find everything that we wanted to badge. But in April of 2014, we did go live with our ambulatory workflow. That was our first go live with RTLS. Sandra really covered the process of how we ended up interacting with our patients. They check in, they get a badge assigned. In order to do that, we did have to create an interface with our EMR. The assignment of the badge actually gets done within our EMR, and the acceptance of that registration is what triggers that interface of information over to the software, the RTLS software. So that's another, building these interfaces is another task that we had to do up front in order to ensure that the data flowed well for our use cases. September of 2014 was when we actually went live with our asset management solutions, like I mentioned, in our hospitals in Fargo and Sioux Falls. And we actually had to create another interface, two of them actually, in order to, prior to implementing and going live with our asset management, we created an interface with our Biomed software at the time, and then also our maintenance software. Both of those softwares housed the information we needed for our assets that we were going to be badging. So again, the assignment of the badge actually gets done in those two softwares and then interfaces over to the Intelligent Insights software. One of the main use cases early on for our asset management, it was definitely to be able to find equipment when we were looking for it, but really we used it for our PAR management. We created a dashboard internally using the information that was out there from the hardware and the software to create a visual of, so our supply chain team could see in real time for all of their supply rooms how many tagged assets were in those rooms at any given time. So they really tailored and created a process around being able to have that information in real time. In the past, they would have had to make several trips throughout the hospital to check on those rooms manually to see how many were there, make note of that, and then replenish at that point. But that upfront piece was really automated in the fact that now at any given time on a dashboard in their central storage room, they can see how many are currently in a location and replenish based on that. Starting in 2016, we did start to roll out assigning badges to staff at our Fargo hospital locations. We did have some older technology, a couple pockets of older technology that staff were wearing badges already for purposes of staff duress. So we had that going in Fargo already, but once we understood what our enterprise solution is going to be for RTLS in 2016, we started to replace those older compartmental systems and replacing them with our Sonitor hardware and Insight software. And I think because of the fact that we had some pockets that were wearing badges already, we didn't get a whole lot of pushback from our staff. They understood, the benefits of it when it comes to a staff duress use case. And we really proved out that solution, that staff duress solution, in those pockets, areas where departments were already using a duress system. One of the main ones was our emergency department. In 2017, there was a new hospital built in our Fargo market, and at that point, the decision was made for all staff within the hospitals in Fargo to be assigned badges for the purposes of staff duress. So continues to be our only hospital, only market that has staff wearing badges in our hospitals. But I think it's going to allow us to do some things in the future, and it has allowed us to do some contact tracings, as I'll touch on here in a little bit, when it comes to understanding potential infections. But which leads me to, again, starting in March, when for us at least here, when COVID really started to be a factor. Again, we had some experience with how to use RTLS. Our initial use case that we were going to look at was in our emergency department, and our emergency department had a process that they quickly put into place where they would triage to identify respiratory patients and basically send them to a respiratory waiting area. It had been the PEDS waiting area before, but we did some shuffling and they were going to use that as the respiratory waiting area. We set up some generic badges to hand to these respiratory patients. I had mentioned with the Moorhead Clinic scenario, we had an interface built to where we could assign badges directly to patients that presented at the Moorhead Clinic. But that interface would have had to have been modified and create a new interface to work in our emergency department. So we didn't have the time to do that piece of it. So what we did was we just set up some generic badges, numbered 1 through however many badges we made available. And we made note within the patient's record in the EMR which badge we assigned to them, so that if we needed to go back, if a patient ended up being positive, we could go back, see which badge was assigned to them, and report based on that. So when the patients presented to the emergency department, we handed them a badge. We noted in their EMR which badge we handed to them, and then they would keep that badge until the end of the visit, at which point, much like in our clinic workflow, we would collect the badge from them, clean it, put it back into circulation to be used again for another patient. We actually, because of some of the decisions our emergency department made, we actually only use this process for a period of a couple weeks. Our emergency department made the choice that as soon as any patients that were directed to our respiratory side of the emergency department, the first staff member that came into contact with them in the waiting room and subsequently in any of the exam rooms was going in full PPE. So at that point, the determination was made that since our staff are in full PPE when they're coming into contact, that we would discontinue that process. However, our use of RTLS for contact tracing didn't stop there. We shifted to, at that point, we started having staff that were starting to test positive for COVID. So we shifted our focus to, at least in the Fargo market again, because that's the only market we had staff who were badged in our hospitals. But we started to focus on staff, and once they were testing positive, how do we quickly use the reports that Keith has shown to understand who and what those staff members have come into contact with. In the past, our infection prevention team has used the traditional methods of going into the EMR and seeing who's signed into that patient's record, as well as, like Keith mentioned, long drawn out interview processes to try and get a full picture of who may have come into contact with, in this case, a patient that was infected, but in our case, a staff member that was infected. In working closely with our infection prevention team, we used two different reports. The one was what Keith just showed. We could enter, a certain staff member and their tag, and see very quickly any other staff members, because all of our staff members were badged, any other staff members that that individual came into contact with. We are not badging our patients within the hospitals, so that report did not give us the patients that staff member potentially came into contact with. However, we ran a different report that shows the history of that tag, the history of locations for that tag. We could run off a report that gave our infection prevention team at least a list of exam rooms, inpatient rooms that staff member entered and how long they were in that room to kind of to supplement that the report that Keith referenced a little earlier. So our infection prevention team found this very valuable. They anytime a staff member tested positive, we would provide those two reports for them. It really did fill in the gaps for them with information they did not have access to before. Using the EMR method to see who was in that patient's chart gave them more people than actually came into face-to-face contact with the patient. So we supplemented that with, here is all the people that actually entered that patient's room. And it also catches staff that don't interact with the EMR, but may have entered the room. So they thought that our infection prevention team found this information to be very valuable. Their next steps then, of course, would be to work with our employee health and occupational medicine teams, to understand what those next steps are, and follow the processes they're used to following from there on. So that really covers how we're using RTLS data now, and continue to use it for contact tracing. That is everything I have.
Great, thanks, Jim. Linda, we'll hand it back to you.
Okay, yeah, we have a couple of questions. I think they're probably mainly aimed at Jim. What value have your staff seen in being badged?
The main value is feeling the safety of knowing that at any time, prior to COVID, I will say for sure, but the safety of knowing at any time they can press a button on their badge and it triggers our security team to respond. The staff duress use case that I mentioned, that's exactly how that process works. The staff's wearing a badge. If they feel unsafe, that a patient is becoming aggressive, a family member is becoming aggressive, they can push a button on their badge, which sends an alert to our security team. Security dispatches the nearest officer to that location, and it all happens within a matter of just a few minutes. Now the using it for contact tracing for COVID is new, newer for us, but haven't received feedback from staff on the benefits, obviously, that come with that. But safety is the number one thing that our staff feel right now.
And I'll add to that, if I may, that when you are badging patients also, staff also benefit by knowing that any contact they've had with that potential infectious person would be easily identified so they could receive treatment if it's appropriate.
Okay, again on badges, do staff get a permanent badge or shift-to-shift badge? And also including that is, do PPE staff wear badges inside or outside, and how does it perform?
To answer the first question, yes, they are assigned a badge that is their permanent badge. They're to treat it just like their identification badge and are expected to wear it whenever they are at work. So it goes with them wherever they go while they're in the hospital. As far as PPE, Sandra may be able to answer that question a little bit better, but there are challenges with when they are wearing full PPE, if the badge is underneath their gown, some of those types of things, it can interfere some with with the sound, with the ultrasound and making contact. Not to say that it completely eliminates the ability to communicate with that badge, but for best performance, they would want to wear it on the outside of any PPE that they may be wearing.
Yeah, and Jim, I can add a little bit. So we do have examples where staff members wear it, under a lab coat. We have examples where patients that are tagged might have the tag around their ankle, and so pants would cover it, and the signal does still transmit, gets received and transmit. I would also say that we've designed, at least from a staff badge standpoint, which is the tag and badge that Sanford is using, a badge that's designed like an ID badge with the microphone that receives the ultrasound located on the top edge. So there's less issue, if you will, of a tag flipping around and maybe facing the body versus facing outwards because it's on the top edge. And also from a clothing standpoint, makes it maybe more flexible in terms of where that tag can be worn to both expose as much of the microphone as possible. But as I mentioned, we've had many examples of light clothing that really doesn't have an impact on receiving or transmitting signal.
Okay, Keith spoke about the speed benefits of ultrasound RTLS. This attendee was wondering if any hospitals have issues with interference or ultrasound concerns.
I can respond to that. So the frequency at which we transmit ultrasound does not interfere with any standard medical equipment. So they're all at different frequencies. So there is no interference. The one area that we evaluate when we're looking at facilities are occupancy sensors. So those sensors that automatically turn lights on. Typically, those are not in patient areas, but there are some brands that are ultrasound based, and so there's an opportunity to evaluate that. Often those technologies have dual technologies, ultrasound and IR, so you can turn off the ultrasound and just leverage the IR to turn room lights on and off. And then there's some microphonic technologies that are also available. But if we evaluate a facility and recognize that that's a potential technology that's being used, we work with the facility to make sure that we get the right solution in place to overcome it.
Okay, so how do you work with contractors? Do you have a method of notifying them?
Is there a little more to that question? I want to make sure we understand it.
No, that's all that is written down.
Okay. Well, I mean, I think from the Sonitor side, we work with a variety of contractors, and I'm wondering if maybe that's a question on how do you manage contractors coming into a facility? Perhaps that's the question, so that, you know, from a tracking standpoint, you can also not just manage patients, visitors, and staff, but contractors as well. And I think just similarly, as you can assign a tag to a patient or a visitor, you can assign a tag to a contractor as well, so that you can monitor their journey throughout your facility. And at the end of their shift or at the end of their project, they can return that tag, and you can get the same level of reports on a contractor that you can on either a patient, a staff member, or even a visitor and an asset.
Yeah, but attendee has just chimed in, said yes, tracking contractors and notifying them after they've left.
Yep, because the badges get assigned, you know, to a unique individual. As Keith and Jim both talked about, sort of being able to look back at reports and understanding where they've been and what they've been in contact with. As a facility, you'll have that information, so you can easily reach back out to that contractor and communicate with them.
Okay, so what is the range accuracy of RTLS?
So it is very technology dependent, and I will speak to ultrasound. Ultrasound can get down to what we refer to as chair level, which is basically giving you the ability to get down to, you know, about 3 to 4 feet squared. So we've demonstrated infusion chairs, you know, if you think about dialysis as an example of a use case. So we've been able to get down to what we call chair level, and that's generally in a, you know, 4 by 4 foot or 4 by 5 foot area.
Okay, this question is directed to Jim. Probably be our last one as we're coming up to our hour. So Jim, this attendee wants to know, how many people does it take to maintain your RTLS?
That's a very good question. So I don't know that I have a specific number, but that's one of the challenges I think that we're facing, is to find that right number. So we do have support that's needed from an IT standpoint, and a team to kind of be the main contact for the application, and for purposes of troubleshooting and keeping the software going. And then we also have a department that is responsible for maintaining the hardware piece of it. So the location transmitters and the badges are powered by battery. So there are, batteries that need to be changed and maintained. So I wish I had a number. I think that's kind of the balance, is to understand how exactly what resources are needed. But when doing your planning, having processes in place before you go live for how you're going to maintain your hardware is very, very important.